Hi everybody, this is just a quick intro to lipids. We'll talk a lot more about this during endocrine, I'll come back to it, but I figure it's a good time to bring it up since it's so essential to cardiovascular. And when we talk about, or when you watch the acute coronary syndrome lecture, it's going to come into play there as well. Essentially, you've got two major types of cholesterol that we care about from a laboratory perspective. There's low-density lipoprotein, or LDL, and high-density lipoprotein. So these things actually aren't cholesterol. What they are proteins that transport cholesterol. So LDL brings cholesterol from the liver to the cells, and HDL is kind of like a cholesterol scavenger that brings it back to the liver. It's thought that high levels of HDL are good and that actually decreases risk of heart disease, and that low levels actually are an increase in risk of heart disease. And low density LDL is considered the bad cholesterol, and too high of it results in buildup in the inner walls of certain arteries, and that can cause a rupture and clotting and an infarction ultimately. Triglycerides are fat made by the body, usually go hand in hand with high LDL and also hyperglycemia as well for diabetic patients. There aren't really LDL goals anymore. Those kind of went out the window. Basically, you treat the patient depending on what condition they have, and you usually just do statin therapy. You don't really monitor their LDL with the exception of a couple things. So again, our LDL is the primary concern. And while this is a little bit outdated, basically right now they say if you did check somebody's LDL and it was above 190 and they didn't have any other reason to be on cholesterol lowering therapy, you would go ahead and treat them at that point. But otherwise, if they meet certain criteria, like if they've had a heart attack, it doesn't matter what their LDL is, they're still going to be on a statin based on guideline recommendations. Other goals aren't super important. HDL, the goal is to be between 40 and 60. You don't really manage this, and in fact, this is generally the one that can be managed most traditionally with lifestyle changes. So dietary changes and exercise can usually raise HDL better than really any medications we have. We don't really have a lot of medications that we use to target HDL, if any. Total cholesterol is what is measured when you do a cholesterol test on somebody, and then we calculate LDL and other things off of that total number. So it's not really as important as LDL is. We don't care about it too much. Triglycerides, the point to remember about triglycerides, they have a really high range, so you have to be quite a bit outside to be considered high. So like borderline high, 150 to 99, pretty high, 200 to 499, over 500, very high. One thing to remember is that because, again, this is LDL is a calculation of other lipid levels, so they'll measure your total cholesterol, it'll measure your trigs, and then it does a calculation on how to get to the LDL. So if somebody has triglycerides that are really high, it actually makes it so the calculator can't figure out how much LDL you have, so you might not be able to have that baseline LDL established in those patients. Not really super important, but just something to consider. These are old guidelines. We used to have all these targeted goals for LDL management for different risk categories, but that's fallen out of favor, and we don't target these specific categories. And basically the reason why is because there wasn't really any benefit shown for aggressive goal targeting for certain patients, especially this was probably the most controversial, this optional goal of less than 70 for people with really high risk equivalents or 10-year risk greater than 20%. That was something that just never panned out from an evidence base, so they removed it altogether. But I thought I'd throw it in there just for historical purposes. The 2013 CHEST guidelines have the following information, and there's some controversy here, but an LDL below 70 has never been proven to prevent heart attack or stroke, so anyway, that's the point of removing that. So who did they say should take a statin? When I say take a statin, statins are the major drugs that lower LDL, so that's really what we're talking about here. Everything else doesn't really matter from a lipid treating perspective. Talk about the drugs very briefly during this lecture, go into them a little bit more detail next spring, because there are a lot of uses for them situationally, but statins are the lion's share of why this is important. And specifically for people with acute coronary syndrome or other CV disease, statins are the primary thing we need to be looking at here. So who should take a statin? Anyone with cardiovascular disease, angina, previous heart attack, stroke, or related condition, anyone with LDL over 190, Anyone with diabetes aged 40 to 75, and again, that's regardless of LDL. Same with the first bullet point. Doesn't matter what LDL you have here. And anyone greater than 7.5% chance of having a heart attack or stroke or developing CV disease in the next 10 years. So that's that risk calculator that we've already talked about and you guys have talked about in other classes. And this is, I bolded this because this is a really controversial statement, because if you go and plug in like a 65 or 70-year-old person into the risk calculator and actually give them normal lab values, like they don't smoke, they don't have anything else wrong with them. So basically like a healthy 65-year-old, 70-year-old. I can't remember where the age cutoff is, but it's somewhere in there. But the point is that you end up with that person calculating into a higher risk of heart attack or stroke just by the fact that they're an older adult. That's what happens. That's what a lot of people die from when they're older and they don't have any complications. Eventually your body's arteries give out in one way or another, and strokes and heart attacks are a big risk factor for elderly patients. So in this case, the guidelines are directing you towards statin therapy in some patient groups where otherwise it wouldn't be intuitive to start a medication on somebody who is otherwise fairly healthy. And that's where there's a little bit of controversy. Ultimately, you don't have to prescribe a statin. Guidelines are guidelines. They aren't a firm law. You aren't going to get arrested if you don't do it. But I think it's worth bringing it up with your patients and saying, the guidelines would recommend we start this. There's not maybe firm evidence to support this. And yes, you are healthy, but it might reduce the risk of having an event in the future. It might be worth talking about. I don't think you need to force statins on people, but I do believe that you need to give people the options based on what the major groups that we follow for guideline recommendations are recommending. So that's my 2 cents on the topic. And again, we'll revisit this again next spring and talk about it in a little more detail. All right. The risk calculator, cvriskcalculator.com. Again, this is the thing. We talked about this already a little bit. I'm not going to go through it again. Lifestyle changes, weight reduction, exercise, physical activity, dietary changes, plant stanols, sterols, fiber can help with this. Ultimately, some people will have hereditary increases in LDL. I'll give you my aunt. My aunt is in her early 70s, but she's very healthy. She's pretty active. She is a vegetarian, so she eats high plant-based diet. I think she's a pretty healthy person. But she just has high LDL. She can't really do anything about it, regardless of what dietary changes she makes. She's already eating a pretty ideal diet from a cholesterol modification point of view. So some people will just have that to begin with, and you can't really do anything about it. HDL, on the other hand, can be modified more aggressively with dietary and exercise regimens. At least it tends to be able to. Okay, so first step in therapy, we really want to focus on LDL and so I say lower LDL, and maybe I'll update this a little bit here. So this is where it gets confusing, right? You want to quote unquote lower LDL. Do we really care about lowering LDL? Not always. We just care about starting a statin on somebody. And I'll elaborate more on this during the acute coronary syndrome lecture and why this is important, but just follow with me for now. Now, if you're above 190 and otherwise healthy, yes, then we want to lower your LDL. But if you just have diabetes or you just have some sort of other cardiovascular issue, or you've had a stroke or heart attack in the past, you're just on a statin, that's it. We don't really care about what the level is because, again, targeting aggressive LDL levels with statin therapy hasn't been shown to be beneficial. Next step, so if needed, lower triglycerides. So if you're greater than 500, you're probably going to have to address your triglycerides first. Unless you meet some of those other criteria to just start on a statin right away, but it'll be difficult to figure out what your LDL is. We'll talk about fibrates a little bit, and then raise HDL. This is, put a little note next to this, almost never done clinically. It's not to say no one takes niacin. Some people do, but it's just, generally speaking, people are on enough medications as it is, and there's no real advantage to raising HDL that's thought to be substantially an improvement in somebody's overall mortality. So it's not really done routinely. Certainly if somebody had chronically low HDL and they're open to taking something, you could try niacin. Statins raise HDL a very small amount, not substantially though. More on statins. So statins in general, what are they? They're HMG-CoA reductase inhibitors, which is an enzyme that works hepatically to prevent the formation of cholesterol. So the HMG-CoA reductase enzyme is sort of the rate-limiting step in forming cholesterol within the liver, and statins stop it, so you don't form as much cholesterol. Therefore, your LDL goes down substantially because it's not bringing cholesterol to other places in the body. Statins are, besides a very new class of drug that we're going to talk about really quickly here at the end of the lecture, are the most potent LDL lowering drugs on the market. They lower trigs a little bit depending on the agent, and they can raise HDL a modest amount. Proven reductions in CHD mortality, stroke, coronary procedures, total mortality. Statins are probably one of the best studied medication classes on the market right now, and they have very overwhelming evidence for their use in a positive light. It's just, there's not really another class of drug out there that has the broad spectrum mortality benefits in cardiovascular population with anybody with these risk factors that statins do. They just are simply incredibly well studied. They've got lots of data behind them, and you should feel pretty confident prescribing them to somebody. Adverse effects, myopathy is probably the most common one, so people get muscle pains. Full-on muscle breakdown or rhabdomyolysis is quite rare. Elevated LFTs, actually this has changed. Sorry, my other lecture is more updated than this mini one here. Elevated LFTs, baseline. Actually, there's been some studies that have shown that statins aren't more likely to raise LFTs than somebody not on a statin. So if you randomize it to placebo or whatever, or a control group on a standard set of medications, it's not more likely to raise it. So that's really probably unfounded that statins do anything to the liver. Basically, get a baseline LFT. If you see signs and symptoms of liver failure, you could always test, or if you think the person's high risk, like maybe they're an alcoholic or something like that, then maybe consider it. Otherwise, you don't need to get follow-up labs with that. Simvastatin, atorvastatin, and lovastatin all have CYP interactions, so we do need to consider that. People are more likely to get side effects like myopathies if there's a major CYP interaction and that patient is getting higher concentrations of statin in their blood than they otherwise would normally. So there might be some dose restrictions. Simvastatin's the big one with this one that you might see flagging with drug interactions. Like, for example, simvastatin and amlodipine don't get along very well, so we dose reduce simvastatin substantially in patients on amlodipine. Just looking at percentage and reduction in LDL cholesterol, you've got two highly potent statins, and I would say this chart's not quite accurate because rosuvastatin probably is closer to the 60 mark, so I'd say it's above atorvastatin based on what I've read and what I've understand. But atorvastatin and rosuvastatin are considered highly potent statins. Simvastatin's kind of like the mid-potency, and Prava and Fluva are lower potency statins. So when we talk about acute coronary syndrome, one of the recommendations post-MI is that you start somebody on a high-dose, high-potency statin. So you just go straight to 40 milligrams of atorvastatin or 20 milligrams of rosuvastatin. Rosuvastatin's Crestor, brand name. Atorvastatin is Lipitor, so you guys have probably heard of those two medications. But in that case, you're going to be starting somebody on a really high dose, and that's been a new change with the guidelines. Previously, you would ramp people up and target goals specifically. Now it's just like, we don't care about goals. You need to be on this high dose. And there's been some evidence to come out to say that starting somebody on high dose statins right away is more beneficial in the long term than doing like a ramp up or targeting a specific goal. And this is probably a good enough time to say that, again, we're going to talk about this next spring in more detail, but statins have a lot of somewhat unknown benefits behind them. There's interesting evidence that says that statins' benefit doesn't really come from their ability to lower LDL, although it likely has something to do with its adjustments in cholesterol production. But it's thought that they're anti-inflammatory in general as well. They seem to be plaque stabilizing, so that people are less likely to, because they aren't taking all the plaques out of your artery. It's not like they're stopping that process. So the question is why are they so effective? And even if you compare them to other medications that lower cholesterol or anything like that, they do seem to come out ahead. And there must be, researchers have concluded there must be some kind of external mechanism with statins, but we aren't 100% sure. It's just a lot of hypotheses, I should say, out there. The PCSK9 inhibitors are the new drugs. You might have seen these advertised on TV occasionally. They're really expensive. They're biologic agents that lower cholesterol. And I'll talk about them more next spring, but this is going to be your forum discussion for the semester, and I'll put this up probably in the next week. You'll have until the end of the semester to do it, so you have a full month or so to work on it, if not a little bit more than that. And again, I'll put the instructions up. It's pretty clear. I basically want you guys to do your own research, answer your own questions, and then respond to a peer. And that's about it. I'm not going to really grade it too heavily, and basically, unless you don't do it, you lose points. So just make sure you're paying attention to that, and I'll put that post up shortly here, probably towards the end of this coming week. Other agents, niacin was the drug that was used to lower cholesterol before statins existed. It's not really used very much anymore. It's not super well tolerated, and it's not as effective at lowering LDL as statins. However, it does lower triglycerides and HDL, and increases HDL significantly more than a statin would. So it might have some functionality as an adjunct therapy. There are fibrates called fenofibrate and gemfibrozole, and they mostly lower triglycerides as their role. There's a drug called ezetimibe out there with LDL lowering properties, supposed to be used in conjunction with a statin. Controversial outcomes data. I should say controversial. Whoops. The thing about ezetimibe is that it was studied in combination with a statin, and it was shown to not be more effective at reducing all-cause mortality than the statin alone. So that kind of sunk the drug, and no one was using it. And then they re-ran the data and did another study on it, and actually showed the opposite, that there was some advantage in the additional LDL lowering potential of ezetimibe. So jury's kind of still out on whether or not it's important to use this one. So anyway, that's it for statins. As far as the exam knows, I just want you to be able to recognize statins in general, know a little bit about their mechanism of action, and know that atorvastatin and rosuvastatin are the two high-potency statins that would be used post-acute coronary syndrome, which we'll talk about in the next lecture here. Thanks.